BioBalance Healthcast, episode 137, Gender-Specific Medicine.
BioBalance Healthcast features conversations about positive aging. Your hosts are Dr. Kathy Maupin, Medical Director of BioBalance Health and a leading expert in treating symptoms of aging, and Brett Newcomb, a licensed professional counselor.
Today we're going to talk about gender and gender in medicine and how a group of women started a journal for doctors called Gender-Specific Medicine. And this was done 10 years ago. And these are women from Harvard who felt that women's diseases and the difference between women and men in medicine were underrepresented. So they sent a request to all the women doctors, surgeons, the members of different societies that were women for money to help them start this journal because Harvard wouldn't give them the money. So we all sent money for them to gather research and send us research on specific gender differences in disease. And they have done this, and they did it for 10 years, and just this year, they stopped producing this magazine. There are other journals now that have taken over. But during that time, they had very important, different journal articles than we would see in the JAMA, AMA, or New England Journal of Medicine, all noted to be specific to a gender, not necessarily women, but articles were about men as well, that were different solutions, different diseases, different problems based on different physiology between men and women, which really opened the eyes of many people in this country and was perfectly timed. So it's my favorite journal. I was sad to see it go. But we have an article back from '06 that we pulled up because we thought it was important. Mm-hmm. And you can explain how you looked at this article.
When I first saw this article, what I was struck by is the use of the word gender, because what happens so often, at least in my opinion, what happens so often among disparate disciplines of knowledge is that we often use the same word in different disciplines to mean something different. Mm-hmm. And so if you are talking to me as a research scientist or a medical doctor, mm-hmm. and you use the term gender, mm-hmm. I know because we've had these conversations, mm-hmm. that you were talking about specific distinctions that can be made between males and females in terms of medical concerns, mm-hmm. protocols, data, research, reactivity to medicine, whatever it might be. Mm-hmm. As a social scientist, gender for me, my first thought or reaction to that is more along the realm of psychological differences, mm-hmm. Sex role identity, mm-hmm. stereotyping. You know, are children taught maleness and femaleness because of their genitalia mm-hmm. that they're born with? And then so what does one do, or what happens to a hermaphrodite? And historically, back again mm-hmm. before medicine could tell as quickly and easily mm-hmm. as it can now, if you had a hermaphroditic child, the parents literally had to make a choice. Do you want to raise a male or a female baby? And mm-hmm. so they would gender reference them in terms of boys play with guns. I remember my dad, and I was born in 1947, so I was raised in the 50s in the Deep South. And my dad went into a rage because I wanted a G.I. Joe doll when they came out mm-hmm. to play with. And my dad went nuts because no son of mine will play with dolls. I mean, I got in trouble one time when he came home and I was playing with the little girl next door, and she had a bunch of dolls, and we were sitting on the front porch playing. I was maybe 8 years old, and I got a whipping for that, for playing with dolls.
Wow.
And so the whole marketing structure of the toy industry mm-hmm. came up with the phrase action figure.
Right.
So G.I. Joe is not a doll. He's an action figure.
Right.
So it's okay for boys to play with him. Yeah. So when you look at social science and you talk about gender, then you're talking about role identity, characteristics that are taught. You try to find out, is that culturally derived and assigned, or is that something that comes from within?
What's hardwired?
Yeah, what's hardwired?
So, and we're talking XX, XY.
Yeah.
I mean, we're not talking about how you deal with your XX or XY.
Right.
We're talking about
What
those
makes
are
the
your
difference?
genetics
Yeah. Mm-hmm.
that we know by science, but back in the 50s, we didn't really do that.
Know all of that and didn't approach it that way. And so then in 1965, a Harvard professor came up with transgender as a way to describe people who were genetically assigned a sex identity, you're male, you're female, but felt that they were trapped in the wrong body. That I've never felt as if I were a male. Not I'm homosexual or I'm gay,
right.
but I've never felt as if I were a male, but I've always been treated as if I were male and medically required to be male because I have the appendages of a male.
Right.
And so he said there are a lot of people out there that don't fit this category, and we need a descriptor to be able to discuss them scientifically. So we came up with the word transgender. Well, then that whole thing has
exploded. And I'd look at it as okay, a male baby is was that baby exposed to estrogen? Was that baby exposed to something?
What are the hormones?
Yes. Because what we're exposed to as a baby does change our brain. Like I assume I was exposed to more testosterone than most girls because I was a tomboy. I played with dolls, but I had frogs and crawdads, and I went fishing, and I gutted fish, and I did all those boy things too, and I thought they were fun. I mean, but I played with dolls too. I mean, it wasn't like so I had a lot of both things. And so I look at this as, well, maybe that mom was taking birth control pills when she was when she conceived, maybe up to 12 weeks. She didn't know she was pregnant, or things like that that make a brain, and we now know brains of women and men are different.
Right.
And then they also have the very male brain, the very female brain, and all the different gradations in between that make a what do we call? Yeah, androgyny. So I mean, we now believe and know that there are differences within our genders that are more feminine or more masculine. One of my friends said, I was a female in my last life. In his really deep voice, I loved to arrange flowers. And I said, God love ya.
Yeah.
That's because, I don't know how to arrange flowers.
Well, and how fortunate are we to live in a culture that now tolerates that and accepts it more.
But not totally.
No, more, but not totally. And depending on where you are in the community.
It's how so what we're discussing today, what I'd like to discuss today, is how medicine divides up people and for research, for medicines, for treatments, because it's not about where you are on a continuum of maleness or femaleness. It's about your XY or XX. And basically they've said, they look at groups. They say, this is a group of people, Homo sapiens. That's the first group they look at. Then they divide us by our race when they're doing research. So
if you remember back in school when you studied biology, two names, Gregor Mendel and Bloom. Bloom's taxonomy, which is like kingdom, phylum, genus, and Gregor Mendel talking about XX and XY and the genes, and if you have a blue-eyed, red-headed Caucasian who marries some other thing, what are the children going to look like?
He wasn't right.
He wasn't right.
He said there was only one gene for eye color, and there's like 25.
But that's where we started to learn to think in that breakdown.
Right.
And as a scientist, you were trained to approach a stranger coming in for an interview, to do your own assessment process, to go through a hierarchy of checkpoints.
Right.
And so you start with Homo sapien, male, female, race, white,
age,
weight. I mean, the whole checklist that you have.
That's because we have divided diseases into not usually male and female, but usually by race, by age, by whether you're obese or not obese. And so what a history sounds like when a doctor's dictating a history or writing a history, that it is your name.
And you have classes where you're taught to do it this way.
You have to do it like this, or you get whacked with the ruler or something when you're, you're standing there writing on a chart, and somebody goes, "Stop that! You're doing it wrong."
Yeah.
So you can say, "I had a lovely patient who was, had beautiful red hair and blue eyes." That's not what you say. You say, "I saw Mrs. Blank, who is a 45-year-old female who is somewhat obese." and has the chief problem of blank, and they only give you one chief problem.
And you say what race?
Oh, yes,
45-year-old white female.
45-year-old white female, 45-year-old black female, because they have not divided diseases too much into male and female, except for the gynecology and the urology.
So were you taught black female, African American female, Negro female?
I was taught black.
You were taught black
because I was
because that's
trained,
evolved through the years as well.
I know, but I was trained in looking at races as distinct, and honestly, races are not distinct. We now know that races. Right. We all started out in Africa. As our first genetic fathers were in Africa, we were all black, and then as we progressed through Turkey and came up through and went into Asia, everything changed with mutations. So by saying this, what a physician's saying is there are some diseases that are different genetically for people who are black. And I was taught that word, not African American, because not every black is African American.
Right.
So it was a larger...
There are actually black people in other parts of the world besides African America.
That's right.
Yeah.
France, England,
yeah.
Everywhere. Like whites are everywhere, but some whites are Hispanic whites, but they're not, and so we call them something different because the diseases are divided up. We look at race because there are some diseases that are much more common in Asians, much more common, like high blood pressure in black, whether they're African American or not, and there's a higher rate of diabetes in Hispanics. Part of that is cultural, but most of it is genetic. And as our races melt more, we won't have to do that because the genes will be pretty much the same. We'll all be within this big melting pot. Now, what's going to happen next is that we're going to have individual genetics. We're going to do our individual genetics, and we'll know what we're at risk for, and we'll know what diseases we should be looking at.
We did a podcast on that just last week,
right.
So you can check that on our list.
But the problem here that these women were trying to figure out and trying to handle was that in there was no research until 1980 that was for women. Every disease that was not related to childbearing or a uterus was considered a male disease that women also had, and men were tested, and they then said, we have the same response. We have the same response to medicines, one size fits all. Like if I take one dose of a beta blocker, then that dose for a 6'4" male who weighs 250 pounds is the same dose.
Right.
Well, that's not right.
Right.
It should be divided by size. There are some women who are 6'4" and 250, but not many. And it either by body mass or by body index, or mostly
so we're back to gender. Sometimes by gender.
And mostly by gender, because
there is now data that says males and females metabolize and process the ingredients of those medicines differently.
Right, that's the whole spirit of what we're trying, what this.
But the challenge was to get to the place where we could acquire the data, and that's what gender-specific medicine was arguing for in the beginning.
Right.
Women are different. Nobody's paying attention to that. Nobody will hear that. We can't prove it because it was actually forbidden to include women of childbearing age in research paradigms.
That was by the FDA. The all-knowing FDA kept women out of the studies. And that was to protect women, I guess,
or fetuses.
Or fetuses. And they assumed all women were childbearing. Okay? They didn't say, oh, are you on birth control? Okay, you can be in the study.
Right.
Or are you not, say you're a lesbian and you have a partner who's of the same sex. You're not going to be pregnant, but they wouldn't let you in that study. So that was something that they kept us out of. Therefore, everything we know about heart disease up until the 1990s,
1990s,
is all based on
research on men.
And same with thyroid. We've talked about that before. The thyroid tests that tell us whether we have low thyroid or not are based on 29-year-old males. They were male medical students because there weren't female medical students in the 1940s. So
well, and then
they were not including women in that study, and women are quite different for thyroid.
And specifically applicable to the work that you do with hormone replacement. When you send women to get blood tests to determine the amount of free testosterone in their blood to see if they have a testosterone deficiency, the lab results that come back, the forms that the labs use, define a normal range of free testosterone for men. They don't define one for women at all.
No, we have to use, they say we do not have a test for testosterone for women.
Right.
In other words, we don't know what the normal is. So we know how to test for testosterone because we test for men's testosterone, but we can't give you the normal.
They say, you've got it, but we don't know what it means.
We don't know what it means. And there are lots of different research studies, but for some reason they haven't found them, they don't use them, or they don't care.
Yeah.
I'm not sure. So they use a test that's usually used to determine ovarian masses in adolescents. We use that test, and those normals are not normal. They're looking for a very small range of testosterone, which would indicate that a young person would have an ovarian mass. That's all they have. Or some of the labs have testosterone based on your age, not on your optimal level. So they have an optimal level for men, kind of. They're not very good at that either, but they have an optimal level for men. And then they have nothing for women. And I have to write in the normals for young, healthy women, which is what we're comparing us to when we replace your hormones. We want to get you back to when you were young and healthy. So they don't have the interest in it to even give us that. So, and they explained that they don't have a test for healthy testosterone levels, even though we're ordering it. There's been no demand except for my thousands and thousands and thousands of tests that I've ordered.
Sure.
And now people are starting to order it, but they don't know how to read it because they look down at the normals. They say, oh, you're normal.
Right.
So that's giving women a big disservice. There's so many disservices. We don't have certain drugs that would work great for us, but don't work great for men.
Well, this whole gender issue, going back to the testosterone thing, you have situations where you send, you replace a woman's testosterone, and then she goes to a regular physician and she gets a regular blood test through that physician, and that physician comes back and says, oh my God, your testosterone is way too high. It's really abnormal. They don't have normal for women.
They don't know what normal for women is either.
And so, but they make that judgment based on the numbers that they've been trained to see for men.
Right.
And they don't know the unique gender-based application of the information that you have.
That's right. And what this journal did for us was it gave us the first look of comparing like pain medicines. Women use certain pain medicines differently.
Right.
Between aspirin and Tylenol, men respond to one, women to the other. And same thing with narcotics. Women have more response to some narcotics, men to others. And so if we knew this, if this was in the PDR, if this was in our the little drug books we look things up in, and it said for women use this, for men use this, or this list or this list.
For antidepressants, for thyroid.
Oh, antidepressants are totally different. I mean, I cannot believe I could give.
How do you really feel?
I mean, I've seen so many women on Zoloft. Zoloft doesn't work for women. It only works for men. We know that, but just by trial and error.
Right.
Nobody gets better on Zoloft, who's a woman. But Prozac works great for women. And it may work okay for men, but not generally. So, I mean, doctors get this feeling years after seeing this happen where people come in and went, I tried Zoloft. I don't need an antidepressant because it didn't work.
What you go back to then as a physician is that whole taxonomy of how you categorize, because it's a crapshoot. I mean, I come in and you don't know me and you're trying to listen to my symptom presentation and look at my presentation, and if you have any kind of test, you're looking at that data, and then it's chemistry set. Well, I'll give you a little of this and I'll give you a little of that, and we'll try this, we'll try that, we'll see. And it's, what's your diet, what's your genetic background, what's the diabetes history and the heart history, what's your weight, and gender-related issues.
It should be gender-related issues.
It should be.
But if you don't give a doctor the knowledge
Right.
Say these medicines or these tests, there's even some tests like heart tests that don't work for women. Like women cannot get on a treadmill and you cannot tell by a treadmill test if they're going to have a heart attack. You have to use an ultrasound or an actual cardiac ultrasound and look at the heart, and then put them on the treadmill, and then put them on the ultrasound.
So the classic stress test that they use for men,
right,
will give you a misdiagnosis for women.
Right, and so now we know that we don't do that. Now some people still do it, but we know. But it's taken 10 years. I knew that 10 years ago, and it's taken the world of cardiology to go, oh yeah, we only get this test. And there's also a belief that women don't get heart disease or carotid disease. So a lot of women don't get their heart listened to by their internist or their carotids listened to. And that's very important.
It's critical, and it's so important that we're going to do an entire separate podcast on that the next time that we meet. So we'll be talking about women and cardiac treatment and cardiac information. What we wanted to have this conversation for today was to just talk about the importance of the term gender and the way that this magazine, Gender Medicine, has led to a more open and inclusive level of research. So much so that now after 10 years, this magazine is going away because its job is being taken on by other magazines. And now there is beginning to be increasing levels of research that make the distinctions between male and female genders, looking more specifically into the way women are different from men. And we'll talk specifically about that in our next podcast in terms of what we are learning about women and heart disease. So thank you for listening.
Thank you.
Email your questions or comments to podcast@biobalancehealth.com. You can find the BioBalance Healthcast on iTunes and on YouTube. For more information about bioidentical hormone pellet therapy and other reverse aging solutions, visit biobalancehealth.com or call 314-993-0963. You can find Dr. Maupin on Twitter at Dr. Kathy Maupin and on Facebook at facebook.com/biobalancehealth. Find Brett Newcomb at brettnewcomb.com.